Hello, I'm Dr. Russell Barkley, and I'm a clinical professor of psychiatry at the Virginia Commonwealth University Medical Center in Richmond, Virginia. In this presentation, I want to speak with you about adult ADHD and what you need to know about the nature, the impairments, the causes, and the treatments for adult ADHD. To begin with, it's important to understand that while the public has only recently come to recognize ADHD in adults as a valid condition, the fact is that ADHD in adults has been recognized for more than 240 years or more. In the first reference to ADHD in the medical literature, the German physician Melchior Adam Weichert described a condition of attention disorder that very much resembles today adult ADHD. Subsequently, the Scottish physician Alexander Crichton also published a medical textbook. It's quite possible that Crichton even studied with Weichert during his time getting training in Germany. In any case, Crichton also describes the same condition in adults, but also goes on to talk about another attention disorder as well. Nonetheless, what this shows is that ADHD in adults has been recognized in the medical literature for several hundred years. Not much was done about that, however, until the 1960s and 70s, when follow-up studies of large samples of ADHD children, who were then called hyperactive, were followed into adulthood, and it was discovered that at least 35 to 50% of these cases of ADHD in childhood seem to have persisted into adulthood. These studies were compromised, however, by the fact that there were no valid, reliable, or consensus diagnostic criteria at the time in existence for diagnosing ADHD either in children or adults. That would come later. Nonetheless, studies of these very active, inattentive children followed to adulthood showed that the disorder could persist. At about the same time, Paul Wender and his colleagues at the University of Utah Medical Center were also publishing studies on adults with ADHD and what kinds of medications might be useful for them. But it was in the 1990s when the public was first awakened to the possibility that adults could have ADHD, even though the medical literature and research had been documenting that possibility for quite some time. This largely had to do with the publication of a trade book, Driven to Distraction, by my friend Edward Hollowell and his colleague John Rady, in which he talks about adult ADHD. At the same time, specialty clinics were being set up in the United States to see adults with ADHD. At first, these clinics were started by clinicians who specialized with children, such as child psychiatrists and psychologists. That is because our adult colleagues in psychiatry and psychology did not yet recognize that ADHD could be a legitimate adult diagnosis. So in order to treat these adults, those people already responsible for treating children with ADHD began to open clinics to see these adults. And from there, the information spread out to other clinicians that this was a valid condition in adults, and that many children diagnosed with it in childhood would continue to be ADHD upon reaching adulthood. By the turn of the century in the 2000s, numerous specialty clinics began to operate in the United States and elsewhere, headed by professionals who now did specialize in adult ADHD. And this trend continues to date, so that there has been a growing percentage of adults with ADHD who are getting appropriate diagnosis and care now, whereas in previous decades, this was certainly not the case. How do we diagnose ADHD in children and adults? Currently, we use a manual published by the American Psychiatric Association known as the Diagnostic and Statistical Manual for Mental Disorders. It is now in its 5th edition, published in 2013, and so it is called DSM-5. The DSM criteria for the diagnosis are shown on the following slides. First, there is a list of inattention symptoms that have to occur often, and the individual must have at least 5 or more of these symptoms. These symptoms include problems with failing to give close attention to details, difficulty sustaining attention to tasks, not listening to directions or to others, not following through on instructions, problems with organizing one's tasks or activities, problems with avoiding tasks that require sustained mental effort, what we call procrastination, losing things necessary for tasks, being easily distracted, and being forgetful in daily activities. These are the 9 attention symptoms, and if an adult has at least 5 or more of these, it is considered to be developmentally inappropriate or deviant, and it is the first step toward diagnosis of the disorder. The next set of symptoms deal with hyperactive and impulsive behavior. Again, the adult must have at least 5 of these symptoms. The symptoms must have occurred often or more. This helps to separate these problems from normally occurring behavior in the typical adult and child population. So these symptoms include things like being very fidgety or squirmy in one's seat, leaving the seat in one's classroom or at work inappropriately. For children, it includes running about or climbing on things excessively, although we don't hear that complaint in adults. Difficulty playing quietly or engaging in leisure activities quietly in the case of adults. Seems to always be on the go or driven by a motor, meaning very active behavior. Talks excessively, often blurts out answers before questions are completed, and has difficulty awaiting their turn, such as when waiting in line or in traffic, and so on, and interrupts or intrudes on others impulsively. So these are the 9 symptoms that we look for. Now, the problem with these symptoms is that they mainly apply to children. The hyperactivity declines markedly with age, such that by adulthood, many of these hyperactive symptoms are no longer evident if they were in childhood. It is the symptoms of impulsiveness that are quite persistent. And here you see they mainly have to do with excessive speech and interrupting others while they're talking. But there are other symptoms as well that I will show you in just a moment. There are more criteria besides this. Not only does an adult have to have at least 5 symptoms on either of those lists, doesn't have to be both, just either of them. The symptoms also have to be considered inappropriate for their age. And the best way we measure that is through the use of behavior rating scales that are completed by the adults and by others who know them well. And we can then compare their answers to the answers we would get from the general population. And that helps us to decide just how far from normal the adult is in these symptoms. Now, we do require that the symptoms have developed sometime in childhood or adolescence. And although the DSM-5 says that the symptoms should be present by age 12, that's not really true. They can develop after that as well. Generally, as long as the symptoms have developed sometime around 18 years of age or younger, we would consider this to be a legitimate case of ADHD. And the reason for that is that adults are not very good at recalling exactly when their symptoms might have developed. In fact, my studies show they're often off by about 4 years or more. That is, they often say the symptoms developed about 4 years later than they actually did. So we don't want to place too much emphasis on the age of onset. As long as the symptoms occurred sometime during the developmental period, then we would consider the criteria to have been met. Even then, some people can develop ADHD later in adulthood, secondary to some neurological injury, such as a traumatic brain injury experienced during a fall or a car accident or playing sports, or possibly from some neurologic disease or tumor, such as stroke or dementia or other things. So it's quite possible for people to show the symptoms of ADHD following some event that compromises the integrity of the brain, particularly the front part of the brain. Now, these symptoms have to occur in multiple places, not just one situation. So we look for them to exist in their home life, in their work, in any school settings in which they may be participating, or even out in the community. In the case of adults, we also see whether it affects things like their driving, their management of money, their ability to live with and engage in relationships with other people, and of course, their ability to raise their children also, should they have children. So we're looking across many domains in order to see that the symptoms are affecting at least one or more of these. We want the symptoms to produce significant impairment or harm to the individual so that the individual is not functioning well in those situations that I've mentioned, like their home life or in their work life as well. So we must be seeing that there are adverse consequences that are occurring in these domains of major life activities as an additional requirement for diagnosis. Now, because adult ADHD often interferes with self-awareness, we want to corroborate what the adults tell us about themselves through others who know them well. Because in some cases, particularly with teens and young adults, they often underreport the severity of their problems. So it's very important that we obtain information from elsewhere, especially people who know them well, in order to validate or corroborate these self-reports. Now, mental health professionals also need to exclude other disorders that might be producing problems with attention, such as depression, bipolar disorder, psychosis or schizophrenia, anxiety, and so on. We can usually rule out those other conditions as causing the problem because they don't usually show problems with attention, impulsiveness, and hyperactivity that date back to childhood and have been largely chronic in nature. Only ADHD seems to be a chronic, unremitting pattern of those symptoms that starts in childhood. Now, we also like the symptoms to have persisted for at least 6 months or longer. In the case of adults, that's easy to do, especially since the symptoms developed in childhood or adolescence. Earlier versions of the DSM said that there were 3 types of ADHD. We no longer believe that that is the case. So in DSM-5, we changed the term from subtypes to presentations, so that there is a predominantly inattentive presentation in which mainly the symptoms of inattention are the most problematic. But some people may show up with problems more with impulsiveness and maybe hyperactivity, in which case we would call that the hyperactive impulsive presentation. But the majority of children and adults who come to clinics have the combined presentation, in which they meet criteria for having at least 5 or more symptoms on both lists of symptoms. So now you understand how we go about making a diagnosis of ADHD in adults.